Good afternoon. Oh, good, no echo. We apologize, we're a few minutes behind. We are using a new technology, and we had some folks who were on the wrong meeting, and we think we have everyone on the correct meeting. So thanks everyone for participating in this monthly provider meeting. Christy Lingard did send an agenda out earlier, and we're going to get going on that agenda. First, we have Margaret Aylwine from HHS. Thank you, Margaret, for being here to do an update.
Thank you, Director Fry. Let me check my audio, see if y'all can hear me.
Works great.
Fantastic. So I wanted to provide several updates today. And again, thank you for your time on this agenda. So we have issued several recent bulletins that pertain to both waiver and state plan services. I wanted to take a moment to provide some explanation and highlight those recently issued bulletins and public notices. As you all are well aware, we have been engaged in a process through our waiver renewals, through amendments, and also through state plan amendments to effectuate a series of rate changes and rate updates. So I want to focus a little less on the mechanism through which we make those changes and a little more on how that impacts you as providers. Recognizing that there have been some sequencing of these series of increases. So let me try to give some clarification. There are a set of increases that were put into place effective January 1. That was in concert with the IDRD waiver renewal and the full review and rebasing of rates effective January 1. So there are a series of rate increases that were already in effect that we noticed through either an Appendix K or through another bulletin that were already in place for the waivers effective January 1. So for those that have questions about the recent bulletin that came out this past Friday, recognize that for those services that have already received rate increases that are already in place, those were not included in that bulletin for the purpose of trying to provide clarity on the items that were already in place versus those that were new for July 1. So those rates that were put into place through the waivers, and again, we have to go through some technical elements to make those permanent, were not included, but were already in place through the waiver renewals. That included the updates to respite, the increases to adult day health care, all of the tiered rates for residential habilitation, day activity or day services, employment services, in-home supports, attendant care as it relates to HASKI, and waiver case management. So those were all the waiver increases that were already in effect. What went out this past Friday were additional rate increases for state plan personal care and nursing, as well as waiver personal care and nursing services. So these pertain specifically to the waivers that were identified and reflect updates to personal care, nursing rates, and some of the other attendant care, companion that are in our community long-term care waivers. So wanted to provide that clarification as to the different rate increases and the timeframes on those. We also issued information through both public notice and bulletin for updates to the adult day health care transportation service. Essentially, what we are doing with this is to make the, essentially we had guidelines within our waiver and within our state plan that required provision of transportation within a 15-mile radius. What we wanted to do in concert with ADHC providers is to make transportation essentially look the same whether you are within 15 miles or outside of 15 miles. So that is the nature of the change for ADHC transportation. This allows adult day healthcare providers to contract with our non-emergency medical transportation broker, as well as for participants within 15 miles whose provider may not want to provide the transportation to access the NEMT broker, non-emergency medical transportation broker for that ongoing transportation. So that was also another bulletin that came out recently. I believe that covers the bulletins, but we are receiving a lot of questions through our Medicaid waiver mailbox. We are grouping those questions so that we can be responsive in a comprehensive and consistent manner. So additional information will be coming out if you have sent specific questions in related to those rate notifications. Hope that provides some clarity. We have also received some follow-up questions in terms of the contracting process with Ddsn for waiver services. So I wanted to further clarify that you will continue to contract with Ddsn for the waiver services, the same as you have for the time period April 1 to July 1st. That is for the purpose of ensuring that as the operator of the waiver, Ddsn continues to have oversight and responsibility for ensuring that services are delivered in a manner prescribed by the waiver, as well as any Ddsn standards and directives. So that contracting process will continue to occur for waiver services between Ddsn and the providers individually. Also wanted to provide an update on American Rescue Plan Act funding. So as I mentioned, many of those rate increases and actions between January and July have been the focus of making sure that we are beginning to utilize those ARP funds in support of providers and the provider network, as well as access to services. So we are utilizing funding to help support in the short term those rate increases in the interim before we seek recurring funding. We are continuing to work with a provider work group. Those of you that have been involved expect a follow-up date coming in the upcoming weeks. We want to get through the end of the fiscal year, but we did receive good information and are working through our fiscal modeling for the American Rescue Plan Act funding, and specifically those activities and items geared toward retention within the direct care workforce. So we are being very mindful and very careful in how we distribute the funding to ensure that we don't cause any unintended consequences or increase in movement of direct care workforce. So we want to do it in a way that supports retention of staff. So we have worked through various recommendations on how to best distribute and the methodology that may be best to help support the provider network. We are conducting the fiscal modeling on those recommendations currently. As soon as we have a sense of what that fiscal modeling looks like, given the funding that we've identified, then we will bring that group back together to review what our recommendations are for how to distribute the funds, get any final input, and then issue those forward. We want to make sure that we are being very clear and very transparent in how we are doing that. I do not have a finite time frame that I can tell you other than as soon as we get through with the fiscal modeling, excuse me, we will be getting input again on that final methodology before we issue those retention one-time payments. So we are actively working to get to what we feel is a good approach to distributing those funds. All right, we had a question also come up on a recent call, so I'll take this opportunity to further clarify, and then I will segue back to turning it to our DDSN partners there. We have worked through at least, have worked through several requests for single case agreements. There is a DDSN directive on single case agreements and the process for that. Those do go through DDSN first. The directive outlines the required information, and then thereafter, if DDSN concurs, they will send the information to DHHS. We review in conjunction with available information and then follow up with the provider directly on what our recommended single case agreement amount is, and then thereafter execute. What that means in terms of rehabilitation, residential habilitation, is you will continue to bill at your designated tier of service. And then above and beyond that, if it is indicated and necessary through a single case agreement, the additional funds above and beyond the available tier will be paid through an invoice. So there is a process for that and information available. We try to work through those as timely as possible. We do engage our reimbursement staff. Many of you are familiar with Jeff Saxon. He may be on the call today, but we work through those as received to ensure that it conforms to the required documentation. All right, those were my main updates for today. I'll be glad to turn it back over to my colleagues there at DDSN.
Thank you, Margaret. We're going to pass it over to Lori.
Sure. I put this in the chat, but for those of you who have questions, you can please ask those questions in the tab that says Q&A along the bottom of your Zoom screen. We will monitor those questions and answer them as we can. Margaret, you also should be able to see those if there are any that are specific to HHS. So we'll kind of pause as they come through and figure out, you know, who needs to answer those questions. I will, before I get into the line items on the agenda that are assigned to me, I wanted to piggyback on what Margaret said related to adult day health care transportation and that change that was made. That change requires that all plans and authorizations be updated for people who were participating in the ID waiver that were authorized to receive adult day health care transportation. We sent out a communication, and we're actually going to make those plan amendments and end all of those authorizations here at DDSN, since it's such a quick turnaround. I think we sent that out on Thursday or Friday of last week, and everything will be done and updated prior to the 7/1 effective date. So I just kind of wanted to let you know that. For the next item on the agenda is really about authorizations. There's been a lot of questions and issues related to service authorizations from providers, from case managers. You know, just a couple of general reminders. Service authorizations for waiver services are not something that is new as a service provider. You have always had to have prior authorization prior to completing the service. In the past, DDSN kind of billed what we could, right? If you guys didn't. And so what happened was with one rate for res hab and the way that we did business, it wasn't as, it wasn't as tough of an issue. At this stage of the game with, direct billing to Medicaid, if you don't have a service off and you're billing through Therap won't let you bill, right? And if you're not billing through Therap and you bill without a service auth, you're billing outside of policy. So my thought would be that if you bill and you don't have the service auth and you're looked at in post-payment review, that money would be recouped. We do have some people here who can assist, but you need to call us before you don't have the service auth, right? If you call us, if you call me and say, my service auth is ending tomorrow and I can't get the case manager, there's something that we can do to help you. If you call me and say, my case manager didn't send me a service auth and I haven't had one for 2 weeks, I can help you today forward, but I can't help you 2 weeks ago. So I'm just kind of putting that out there. We have designed a training for case managers around service authorizations. That notification went out, I think, at the beginning of the month. The training is Wednesday morning at 10 a.m. So, for those of you who have case managers, please encourage attendance. If they're unable to attend, we will also record the session. It will be available on Business Tools. Because, as we all work through making sure that service authorizations are a high priority for case managers as well as service providers. The next item on the agenda is around the Therap billing system and the plan for future billing enhancements in the Therap system. So as you guys are aware, when we went live on April 1st, all of the billing in Therap was done through Therap's attendance module. And that was for all services that you guys are providing that can be billed through Therap. On June 1st, we moved to direct case note billing for case management. So the case management system was updated to do direct case notes. The next phase of Therap enhancements will surround the 15-minute unit services, SLP1, and individual employment. Those services will require a standardized ISP that will be attached to the service authorization. It will be required that everyone use the standardized ISP, even if you are not billing through Therap, because you still have to have a service auth. You're going to be receiving your service auths through Therap. When you accept them, it will download a copy of the standardized ISP that has to be used for those 15-minute unit services. The current projection is for that to start August the 1st. Hopefully that's going to happen. The good news is the standardized ISP is not going to change from what the format of the standardized ISP is not really going to change from what it already is. SLP1 providers, individual employment providers are already filling out those ISPs. It will just change to them being attached to the service auth. The last phase in may be in 1 or 2 steps, because we will have the half-day unit day services and the daily residential HAB. The plan is for both of those services to go to ISP billing in the same manner in which the SLP1 and individual employment services are going, but the creation and training and kind of oversight that needs to be provided to the provider network to get to a standardized ISP and those services that doesn't exist right now is a little more of a lift. We are hoping for at least part of that rollout to happen in October. We are hopeful that all of it will, but we'll kind of see. So I really just wanted to let people know what we're working on. related to that. We do have a question about whether new service offs will happen when the rollover happens on 8/1. Yes, you will get automatic, there'll be a migration where Therap will end the current auth on 7/31 and start a new auth on 8/1, and the authorizations will be attached to it. We're gonna do some information sharing prior to it happening, but right now it looks like we've gone back and forth about automatic acknowledgement, right? Because when we did case management, we had to do new service offs for the 6/1 rollout, and we did automatic acknowledgement when we did that. So the issue with the direct services is if your program is wrong at the time, the system has a little bit of trouble trying to figure out where, if you're in more than one program, the system has a little bit of trouble trying to figure out which program to automatically acknowledge. So we're kind of weighing errors it might cause, because I know from a service provider perspective, when you have acknowledged the authorization into the wrong program, it can kind of be a pain in the neck, because you kind of have to go back to the case manager, try to get a new auth so you can get it assigned to the correct program. But I will promise you that we'll do the best that we can to try to make it as painless as possible. The next item on the agenda is around leave days. I sent out your leave day report. I guess it was about a week and a half ago. Remember that the leave day policy is around temporary leave with the intention of the person returning to your program. I want to be sure that providers understand the intention of that leave policy is not to for somebody to go into the hospital, stay for 73 days, and then discharge them, right? That leave day policy is, the intention is that the person is coming back to you. Keep in mind that the 73 leave days that a person receives over the course of their authorization plan year is not dependent on provider. So if the person lives with provider A and provider A uses up 73 days of leave while the person's in the hospital and then says, oh, I can't take them back because, you know, I can't support them. When the person goes to provider B, there's no leave days left. So that's kind of the thing. You really need to make sure that there is a plan for return whenever you're billing those leave days. The other thing is providers need to understand that that report that I'm sending you, only includes leave taken after April 1st if you have billed the leave. So it doesn't count the leave days that you put in the attendance module, but you haven't sent claim in. So all providers need to kind of have their own system for keeping up with leave days. We already have some providers who have billed more leave days than the person is allocated. In those circumstances, I've told you when I send you your report that you need to void that claim with HHS, and I'm also sending that information to Margaret and her group so that they know to be looking for that voiding of the claim. The other thing is that if you are not billing through Therap, I have no way to keep up with how many leave days you have billed for. So it's kind of all on your organization to make sure that I can tell you how many leave days somebody has had at the beginning of April. But from April 1 forward, it's your responsibility to keep up with I'm going to stop and see if I have any questions. So I'm going to kind of go back. Let's see. So there was a question about when providers would be getting their new waiver contracts. The fiscal year 23 contracts for waiver and state plan services or state funded services for residential, employment, waiver case management, and all the day services were sent out last week through DocuSign. So you should have them. They came through DocuSign. So we continue to work with Therap related to, there's a question about whether or not Therap has been making any progress regarding separating the program and location to change to ISP data-driven billing. So from the program and location, even when we get to ISP-driven billing, the program and location is still a big deal. So Therap understands that it is inconvenient for providers to have to get a new authorization if the person moves from one program to another. The issue is that, from my understanding from Therap, it is a very big lift. It's a big change in the coding of their system. So they know that it's an issue. They are working on it, but I do not think that there will be a quick fix to that. So I can't really speak to when that would happen. So there's some more questions about service offs and, timing. So service offs expire with the plan, right? Or any other date the case manager has them set to expire. As providers, you guys are going to need to monitor when service offs are going out of date. Typically, case managers are instructed to do new plans 30 days ahead of time. So you should get your service offs early. There are circumstances where people kind of duck out on their plan and the case manager has to scramble at the last minute. But typically, you should be getting them a couple of weeks before they expire. I would probably set a ticker for, when you start to get a week out and you don't have a service off, there probably needs to be some concern. We have hired a few kind of case management specialists that are going to help do some of the monitoring and some of the pickup work along these situations. But so far, when we've been contacted in advance of a service authorization expiring or the need for a service off, we've been able to react and get folks what they need. So there's a question about, Janet, you might have to help me with this. If a new CTH2 is opening during this period, should be complete enrollment now or after it opened? So I think everybody who meets the criteria of residential need also meets the criteria of a reserved capacity slot. And I really think we need to be enrolling people and providing services as soon as possible.
Based on when the question came in, I'm not sure if it's not actually about service authorization and should you have it before it opens. Right. You have to be authorized to receive the service on the first day you deliver it.
Correct.
So, the person you need to have an authorization for anyone who's moving into a new CTH2. You need to have an authorization in your system, a valid authorization on the first day you want to bill for services.
So I know from a service authorization perspective, there's a lot of concern about the total units calculation in the authorizations, and we are working through those as we can with Therap. Therap understands the issues. I understand the issues. The rollover is likely going to affect the unit calculations, but we're looking at something more than a straight prorated amount of units. So with the rollover, the idea is that the Therap system will look and see what is the prorated amount for the previous, the previous period versus what amount has actually been entered as complete, meaning billed units as well as units in the attendance module. If that amount is greater than the prorated amount, then that amount will be entered on the left side, for a lack of a better way of saying it. And then the right side will be the remaining units. We'll do some training and information sharing with you guys prior to doing that split so that you understand it and we don't get into a situation where we have to have a lot of overlapping offs based on the prorated amount.
Lori?
Yes.
Hey, this is Margaret. I saw a question that came up in the Q&A section as well. It was related to whether ICF rates and adult day healthcare rates would be increased as it relates to requirements to provide nursing services. I would direct your attention to a public notice that was just issued by the agency on June 24th. It explains upcoming actions related to July 1 and the ICF rates. So please take a look at that bulletin, public notice, and we will be providing additional information related to that.
Do you have any more questions out there that I need to address? I don't know. I was trying to kind of look through.
There's a question for finding the leak report.
Say it again.
Question is, where can I find the leave report for our agency?
Right, so we have to actually send the leave report out every month. Your executive director should be receiving it from Yolanda Goodwin. I believe it was sent out, it was either last week or the week before. I think the date on the report, like we ran it as of June 19th. So if you don't have yours, the first course would be to ask your executive director for it. If your executive director didn't receive it, if you'll shoot me an email, I'll see if I can find it for you. Therap intends to put a leave report for you in the provider account, but they don't want to update. It's going to take some. It's going to take some doing for them to do that because of that rule about leave transferring providers. And they don't want to do that until we get the standardized ISP data collection method out there, because if they do it now, it won't work when they get to standardized ISPs, which should be kind of right around the corner. So that's the plan for that.
There's a question about a provider limiting the amount of services provided to someone in SLP, I think it's SLP1, based on the units that are on the service authorization. There's no requirement to provide services that are not being paid for, correct? Correct question. So I assume you're talking about SLP1. And if you are authorized to deliver 10 units and you only deliver 5, there's not a problem with that. Although if the person has been assessed to need 10 and you only delivered 5, it may call into question whether or not they're being appropriately supported. So that's kind of a, no, there's not a requirement that you deliver it. However, if there was an assessment that was correctly done and the person needs it and you don't deliver it, then that could be an issue.
So I think there's some question about the 3% cost of living increase that was approved or is being approved. I don't really know what the deal is with that. I don't know a lot about how that is going to happen for providers that are enrolled directly with HHS, but I can say 2 things. So in the past, when you guys were billing through DDSN got your FTE information. We submitted that as part of our package to then get the money from the General Assembly and pass it to you guys. That is no more. And the reason that is no more is you're not billing through us, right? So that won't happen. I do know that Jeff Saxon has asked for FTE information from the providers. And I think Health and Human Services will likely have to analyze, you know, what they'll do, how they'll do it related to that. So Margaret, I don't know if you want to say anything more.
Yeah, Laura, you're correct about that. Jeff Saxon had sent out requests to all of the providers for your FTE information. I believe that was due last week. He will conduct an analysis. I do not know the financial details, so I won't get into that territory, but he did request that FTE information and is currently conducting his analysis.
All right. I think I'm good now. I can look through my Harley. We won't stop the agenda. I'll let Harley talk a little bit, and then if I see anything else in here, I'll either type an answer or try to get it live.
Okay, thanks, Lori. I just have 2 quick updates. So I'm working with others to develop a FAQ for providers that we'll send out and post on the website. That's based on questions we get during these monthly provider meetings, questions that other staff here at the agency get. And so I'm just letting y'all know that that's forthcoming. And if y'all have questions that you would like answered as part of this FAQ document, please send them to the email address associated with this meeting, the forum agenda and FAQ email address, and we'll be sure that they're answered and included in that FAQ document. I would ask that maybe send by the middle of the month so that we can finalize this and get it posted by late July, early August. And then the other agenda item that I have is just to briefly mention some upcoming surveys that will be that we will be sending out to providers. One is a sub-minimum wage survey. It's been sent previously. And so the goal for this iteration is to collect updated data and some additional information. And so the survey, the data collected, will be used to inform the work of the Sub-Minimum Wage Task Force, which will be convening later this year to address the Sub-Minimum Wage Act that passed. So just be on the lookout for that. It probably will be coming out this week. The other upcoming survey will be related to the DDSN website. So we're working to collect information in a systematic way regarding update or to inform updates to the DDSN website. So we're conducting an internal staff survey right now, but we will, of course, collect feedback from providers so that we can incorporate changes to the website that meet some of the needs that y'all may have, or address some of the questions or comments that y'all have as they relate to the website. That probably will come out later this month or maybe in August, and so I'll provide additional updates on that as needed. But again, we would appreciate any questions y'all would like included on the FAQs, and then we appreciate y'all's feedback in advance on the surveys that are forthcoming. That's it for me. Turn it over to you.
Thanks, Harley. So this is Ann Dalton. I'm Director of Quality Management, and I wanted to share with the group some items that we discussed in the Quality Management meeting this past Friday. I do apologize for those of you who are hearing this for a second time, but I did want to make sure that executive staff from our provider agencies were aware of some of these topics. The first thing I wanted to cover is the National Core Indicator Staff Stability Survey. We currently have 15 providers that have not yet responded to that survey, and I just wanted to stress the importance of having each agency represented in the staff stability survey. The data that we get from this report is very important as we look at vacancies, the frequency, the rate of pay, and how we can better support staff within our system. So for those 15 providers, we will be reaching out. We also have a large number of providers that have started the survey, but they have not yet completed it. So we want to make sure that everyone is participating in that effort. I also wanted to share that the fiscal year 23 review tools for Alliant as our quality improvement organization have been posted on the Ddsn website. If you go to the quality management section on the website, the review tools have been listed under contract compliance, licensing, and also the day and residential observation sections. There are other documents available that include a prep list so that your agency is prepared and knows what they will need to have available for the review, a frequently asked questions page, and other resources for your organization. So again, fiscal year 23 review tools are on the website. There are 11 providers that have had a DHHS waiver review during fiscal year 22. 8 of those providers received results of those reviews last week. So I've been working with those providers to prepare their response. For some, there may be items they would like to have reconsidered. They were able to locate information that might have been missed during the review. In other cases, there will need to be a plan of correction developed in response to those findings. There are 5 additional providers that received notice last week, and I've been working with those providers to get their employee list and list of waiver participants to DHHS. So the actual review for those providers will begin within the coming week. Lori touched on the post-payment claims review process earlier when she was talking about authorizations. This is a process which continues to be in the development stages, but we want to make sure that providers are aware and understand that this process is coming, it's in development, and we will be looking to make sure that each person was eligible for services at the time of the claim. We will make sure that each person was authorized. The service must be authorized in the person's plan. We want to make sure that the units of service align with the authorized units in the plan. And we want to make sure that there is sufficient documentation to support that the service was delivered and that it meets the scope as it was defined in the waiver. So you need to have some sort of documentation in place to demonstrate that the person received a service, that they participated. And we can't stress enough, attendance is not service delivery. So make sure that you're talking about post-payment claims review and getting your documentation in order as you work with staff. There were a few standing items that we discussed in our meeting last week for allegations of abuse, neglect, and exploitation and critical incidents. I just want to remind providers to make sure that you're monitoring timelines to ensure reports are submitted timely. That's within 24 hours for the initial reports and within 10 business days for the non-ICF, non-CRCS settings. Of course, those settings require a final report within 5 calendar days. We also want to remind providers to be sure they are cleaning up their general event reports in Therap. There is a large number of unapproved reports that are hanging out in the system, and we need for all of those reports to be closed out and approved. As new information shared in our meeting on Friday, we talked about the risk management administrative reviews. For those who may not be familiar, Ddsn has a risk division that is currently completing administrative reviews for all of the regional centers whenever there are allegations of abuse, neglect, or exploitation. In certain circumstances, this same team may conduct an administrative review at a community provider agency. And typically that's going to be when there has been a significant injury or there is significant risk to persons served by the agency, which may have to do with concerns about supervision and supports in the plan not matching those that were actually provided. There may be other situations where the team will get involved that will be handled on a case-by-case basis. This is a new process, but there have been 4 of these community-based provider reviews so far this quarter, and we actually have a 5th one that's now underway. The last item I wanted to mention has to do with corrective action plans that are required for material deficiencies. As part of our oversight authority and providing assurances to the Department of Health and Human Services, when Ddsn identifies that there are material deficiencies, we are working with providers to ensure that they are providing a corrective action plan. We want to ensure that services are rendered according to the plan and that the provider is compliant with all policies. When providers fail to meet compliance through the typical remediation process, through their plans of correction to Alliant, through their administrative review process for incident management, that's when they may receive a notice of material deficiency. The plans will be required to include dates of correction for each item. We want to know how the training will be provided to staff if training is identified. And a big issue here is making sure that the training provided is not the routine training that is typically provided during new employee orientation and annual training. We see a lot of plans of correction that come in and they say, oh, we're going to train staff. Well, we want to know what you're going to do different because the training that was in place before didn't work, and that's how we arrived at this situation. We also want to know how the agency is going to increase their monitoring to ensure improvement and how they're going to prevent this particular issue from coming about in the future. So this process, again, continues to evolve. We have had 4 providers with a corrective action plan due in the 4th quarter. And we will be sharing more information over the coming months just to identify trends and talk with providers about how to make sure that they're continuing to be compliant with all of the policies. Thank you.
For upcoming events, I think we have the training next week for authorizations for case managers. I can't think of anything else that we have.
PJ, is there anything upcoming for the providers to know about?
I don't recall any.
Okay, I just wanted to check. Thank you.
I think so.
Well, we have covered all of our topics. We thank everyone for participating in this monthly provider meeting. We will continue to go through the chat, and if there are any questions that were asked that were not answered, we will follow up either individually or to the group in an appropriate mechanism, whether it's this meeting or in an FAQ document, as Harley mentioned. And we look forward to continued collaboration. Thank you.